Good morning, good afternoon, good evening, everybody. Welcome. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health, and I'm here in my capacity as chair of the 3D Commission. The 3D Commission, which was a Rockefeller-Boston University collaboration, focused on the intersection of social determinants, data, and decision-making. The vision behind the commission was to say, as we are broadly beginning to accept the importance of a social determinants agenda, of the conditions of where we live, work, and play in shaping our health, how do we use data to better capture social determinants so that we can inform making better decisions for health? The commission was conceived in 2019, and the reason that's relevant is because it was before the COVID pandemic. And we launched the commission around the time of the COVID pandemic was started. And as everybody might imagine, it sharpened our thinking, and it certainly made the deliberations of the commission that much more relevant and much more important. We released the report of the commission 2 weeks ago, coincident with the UN General Assembly. And we have, in the past couple of weeks, been doing a series of these regional launches. This is the regional launch for Europe, and working with local partners. And the idea, of course, with this commission and any other such effort is to generate ideas that then inflect our collective conversation, both in the academic space and in the practice space. By way of introducing the work of the commission, I'm going to share my screen and show 5 slides that summarize the work of the commission. This is the cover of the report, which is available on our website to download. And these are the commissioners. We had 24 commissioners from all over the world who met together over the course of almost a 2-year period to come up with this report. This is a survey that the commission had commissioned, so to speak, globally to ask what are the key factors that drive people's health. And what you see is in the general public, healthcare remains what the majority of people consider to be driving their health. And that really is I think it's an important reminder for all of us who spend all our time thinking about health and who are now comfortable with the idea of the social and economic impacts on health, recognizing that there remains quite a bit to go to get the general public there. Fundamentally, when we're talking about social determinants, we mean the full range of forces as captured here in this diagram, ranging from commercial factors, governance, places where we live, our neighborhoods, assets, income, education, all of that happening over the life course. And fundamentally, recognizing that these forces all matter calls into question then how is it that we can best apply our understanding of what we measure, from big data all the way to telling stories and ethnographies, to inform how we make decisions that improve these conditions to improve health. This is a schematic that's in the commission report, which on the left shows conceptually how the current decision-making process happens, which is we have a number of competing priorities competing with social determinants that also jostling for space with new data sources, traditional data sources, all going through a funnel, and something eventually emerges decision-making for health. And perhaps a more idealized universe would be where decision-making for health is at the center of a lot of our thinking at the local, national, regional, global level, with all these multiple inputs from new data, traditional data sources, measuring the social determinants to explain how we may do better on moving health forward. The commission's deliberations led to the articulation of 6 principles and 4 recommendations. Briefly, this is the schematic of the principles from the report. The first principle is that all evidence-informed decision-making needs to move beyond healthcare and to take into account the broader determinants of health, really putting front and center the important social determinants in our decision-making about health. Health should be a consideration in decision-making in multiple sectors, recognizing that decisions that affect health happen in housing, in transportation, in finance sectors, not necessarily in health sectors only. Health equity needs to be one of the core considerations in thinking about health. It's not simply good enough to be thinking about overall health, but also need to be thinking about health gaps. And in principle 4, we should be using all available data sources around the determinants of health. And by all available data sources, it means having the imagination and the courage to extend beyond typical data, to look at data that are emerging as like big data, like social media data, yes, but also to look at community-generated stories that all of which can contribute to our understanding of social determinants of health. The data that is collected on social determinants of health should contribute to more transparent and accountable governance, that governance rests on the data and transparently and accountably reports back as to why decisions were made given the data. And fundamentally, this type of decision-making needs to be participatory and inclusive of multiple and diverse perspectives from the community where the data come. And in some respects, hopefully when an audience like this hears these principles, the hoped for reactions to say, well, that all makes sense. That actually feels like a rational elucidation of something that is complex. And the point of these principles really is to try to create a scaffolding for our thinking on which we can build going forward. These principles lead to 4 recommendations. All the recommendations center around international, regional, national, global, local entities. But fundamentally, the first recommendation is to make sure that we are systematically collecting and making available in real time quality data, characterizing the full range of social determinants, education, housing, etc., for all communities, locally and nationally. That we need to have transparent systems about collecting data and be explicit that we are using these data in decision-making. That we should embed follow-up monitoring to ensure accountability. So both transparently collecting data, but then be accountable for decisions that emerge from these data, or be accountable for decisions that do not take data into account. And finally, to center community engagement in acquisition and interpretation of data, and to make sure that data itself is available to relevant communities, and the decisions that emerge from it are also made available to and accountable to the communities. So these principles and recommendations, which, as I said, we introduced, we've now been having these regional conversations. It's been fascinating to hear from regional experts about how these thoughts intersect with particular regional considerations. And that's exactly what we are here to do today. We are very fortunate to have an outstanding panel with us, but I'm going to turn over the podium to my colleague on this, Jeffrey Sturcio. Dr. Sturcio was the chairman of Rabin Martin, one of the commissioners and really one of the intellectual architects of this work. And Jeff is going to lead us through the panel. Jeff, over to you. I think you're on mute, Jeff.
Thank you. Thanks so much. And it's really a privilege for me to be able to moderate this panel discussion. Now that Sandra has given us an introduction to the principles and recommendations of the 3D Commission, what we'll be exploring in the next hour are the various regional challenges in Europe to public health, and the potential for incorporating a data-driven approach for improving decision-making for health grounded in an understanding of the social determinants. We'll also be taking a look at potential opportunities for building a new foundation of public trust in decision-making grounded in political will, technical capacities, and community engagement. So I'm looking forward to hearing from our panelists. We'll start with an intervention from each of them and then have a conversation among the panelists on the range of issues that they're finding in their work on how to develop and implement evidence-based policies that will improve population health in a sustainable and equitable way. We'll also have an opportunity to hear from the audience. So if you have questions, please just type them into the Q&A and we'll come to those in the second half of our conversation this morning. Or afternoon, depending on where you are. Now, let me start by introducing our panelists. We have Professor Seval Akgün from who's a professor of public health and medicine at Başkent University School of Medicine in Ankara, Turkey. And she also is at the University of North Carolina, Pembroke in the USA. She has more than 35 years of strong experience in public health, quality, and accreditation in healthcare, and has also worked on patient safety and epidemiological studies. She's also a quality expert and serves Başkent University as their chief quality officer for the university and its network of 10 hospitals and 16 hemodialysis centers. Next is Terje Eikemo, who's the leader of CHAIN, the Center for Global Health Inequalities Research at the Norwegian University of Science and Technology in Trondheim. CHAIN aims to monitor, explain, and reduce social inequalities in health within and between countries worldwide by the identification of effective interventions in collaboration with partners in academe, policy, and practice. CHAIN also coordinates a global socioeconomic network under the umbrella of the Global Burden of Disease Study, which will estimate the global burden of disease that can be attributable to low education and other social and economic factors. And our third panelist is Martin Mckee. Martin is, I'm sure, well known to our audience. He's professor of European Public Health and medical director of the London School of Hygiene and Tropical Medicine. He's also research director of the European Observatory on Health Systems and Policies and past president of the European Public Health Association. We had hoped to have Katie Dane with us, the CEO of the NCD Alliance, but unfortunately, conflict made it impossible for us to for her to join us. But I'm looking forward to hearing from Professor Aklan, Aikamo, and Mckee. Why don't we start, Saval, with you? And let me just ask you, as in your role as a professor of public health, what steps are you and your colleagues taking to ensure that a more holistic view of the social determinants of health is integrated into your research and practice? Oh, you're on mute. Just unmute yourself.
Okay. Thank you, Mr. Starchi. Good afternoon or good morning to everybody. Thank you for inviting and giving me the opportunity to appear as a speaker at this regional launch series Europe. I'm really very much honored being a part of this very important event. And I also would like to extend my heartiest congratulations to Professor Sandra Galea and you, Mr. Jeffrey Starchio, and your great team, of course, for developing such a wonderful report. I reviewed the report. It was really very well done, an excellent report, and all your efforts in this area really very valuable. I totally agree with you that the choices we make in the collection and use of information for health determine our effectiveness in identifying problems, defining priorities, identifying innovative solutions, and allocating resources for improved health outcomes. Health and health inequalities are largely determined by living conditions and wider social, economic, environmental, cultural, and political factors indeed. And many of our 21st century challenges, such as obesity, that it's one of my main areas. I was a PhD in nutrition and working on many nutritional survey with Ministry of Health, and mental well-being and climate change involve multiple interacting causal factors and lack a clear linear solution. A health equity agenda requires a different kind of analysis of health status than is traditionally undertaken. And Turkey is also facing challenges as the country is shifting to an epidemiologic pattern similar to developed countries. However, despite all those fundamental realities, there has been little awareness and political willingness today of the ramification that greater information use can have for advancing health, and even less attention has been given to systems needed to provide timely, accurate, and relevant information on social determinants of health, at least in this part of the world. There's a need to prioritize programs for vulnerable population and place a strategy in this part of the world too. In addition, few policymakers and also clinicians consider the importance of data on social determinants of health in this part of the world. And most practical indicators for social determinants of health and in health inequalities in this region, as well as the community assets that can address them, usually on morbidity or mortality, or composite indexes. Actually, there are increasing number of data sources. We have big data, we have analytic tools. However, there is also lack of awareness among clinicians and policymakers. And also, one of other challenge in my work here or in my research here, standardization in what variables are sensitive and exactly define the social determinants of health and the appropriate action to address these variables. And the data that we receive, especially on social determinants of health, is also sometimes inconsistent and not accurate and transparent. However, we all know that good decision on effective policies, services, behaviors require timely, accurate, and relevant information. And the citizen also requires such information to choose healthy behaviors, to demand effective policies and services, and to hold the policymakers, governments accountable for the allocation and use of resources for health. Information on social determinants of health is also needed to meet translational needs, such as for the detection and control of consequences of current epidemiologic pattern in Turkey. COVID-19 has amply demonstrated the need and potential benefits of sensitive and transparent system for tracking health events and the consequences. Although we have data on the social determinants of health should contribute to better, more transparent, and more accountable governance, which is not the case most of the time. So I can summarize all the challenges and so the data on social determinants of health during my practices and my researches here. These are the main challenges. We don't have enough reliable, accurate, and consistent data on social determinants, and also the political willingness, as well as the awareness about the importance of social determinants, data on social determinants of health is lacking here.
Well, thanks so much, Seval, and you've gotten us off to a good start. I think those key points you made about the need for political will, the need for data, and the awareness on the part of practitioners that social determinants really do have an impact on the long-term health of people are really critical aspects of the issues we want to discuss this morning. Let me turn to Terje Aikamo next. And I'm intrigued to know more about your Center for Global Health Inequalities research. How can you, tell us, how do you go about explaining and reducing social inequalities in health? And how does an understanding of the social determinants really help to achieve that goal?
Thank you, Jeffrey, for your, first of all, your nice introduction, and for inviting me here, and for the important work that you've been doing in the Commission and the Commission's report, not least, and its recommendations, which I think and hope will provide new targets for research and policymakers in the future. As noted, I am the leader of Chain, which is a center based in Trondheim, in Norway, where I'm currently based, which is aiming to be a surveillance agent on health inequalities worldwide. But we are focusing perhaps even globally, but also in Europe, on Norway as a country, but also on regional levels. And I think this points back to the holistic approach as proposed by the Commission, that you want to look at local, national, global aspects. The Chain also tries to incorporate other elements of this holistic approach as well. And I think this has to involve not only the regional level, but also the level of analysis, going from basically the individual level to genetic factors, to societal factors and institutional factors. And we're trying to do all of that in a comprehensive manner. Also by taking a life course approach, see how inequalities are being transmitted from one generation to the next, from childhood into adulthood, into old age. So there are so many dimensions to take into account. And I think that a holistic approach is extremely important and valuable, and it really shows the directions we as researchers should take. But we have to keep in mind that the complexity of our data can never really meet the complexity of our real social world. But in Chain, we have taken huge steps, we think, to get closer to holistic approaches by thinking new in terms of data capacity building. And I wanted to highlight a few of the things that we're doing in our center. To sum up, we are monitoring health inequalities. We are trying to explain the mechanisms, the causal mechanisms involved, and we are also attempting to identify interventions, policies that have the potential to reduce inequalities. And I think all these three aims are also key aims of the Commission's report. So I think we overlap quite nicely in this respect. So our vision basically is to promote health equity through data capacity building and through research excellence. And our aim is to provide advanced monitoring of such inequalities in health, mortality, and their social determinants in all countries. But comparative data with sufficient depth, which cover many countries, is of course hard to find, and the availability and quality of existing data vary enormously. And sadly, this is also disfavoring countries in the global south. But I will provide you with 3 examples of what we're doing in Train to address these challenges. The first thing we do is that we are creating a global data and infrastructure, research infrastructure. So we're basically trying to map and collect existing data on mortality, chronic conditions, infectious diseases, and living conditions, all of which can be broken down to socioeconomic position in as many countries as possible. And we will make these data available to others to the degree that data sharing rules allow us to. But of course, in order to do all this, we need global collaboration. But our second strategy, I think that it's also a very exciting one. We are trying to plan and implement the first global health equity survey. There have been a few attempts out there, but we will base our survey on the European Social Survey. In 2014, we implemented a health module into the European Social Survey, and this was the first large-scale survey that has been able to combine detailed measures of health behaviors, living condition factors, working conditions, and the social stratification systems of societies. And now we're going to expand this to other world regions and see whether it is really possible to conduct such a worldwide survey. We expect, of course, many challenges, and not all social stratification elements are equally important in all societies, but we're going to make an attempt. Our last, our third strategy that I'm going to mention here is to implement education and other socioeconomic factors into the global burden of disease study, also in collaboration, of course, with IHME in Washington. And this work has progressed well, and our first study was just published in The Lancet on parental education and child mortality. And this work was supported also by the 3D Commission, I should mention. And so I think we've taken some important steps globally. But as this is a European launch, I should perhaps mention that being in Europe, we are uniquely placed to use excellent data. But even the data we have here can be improved in terms of improving comparability and improving methods we're using to really exploit these data in a good fashion. So this was just a brief summary of some of our work that goes well together with the aims of the Commission's report, I would suppose.
Well, thanks, Terry. And I want to just highlight 2 of the points you made. One is that, you talked about how your center is looking not just at the individual, that as important as it is to understand the individual elements of health, but also on all of the social factors that impinge on individual health. And that's consistent with the 3D Commission's effort to take a holistic view of how where people live, learn, work, and play has an impact on their health condition and their health status. The other point that you made is that you can't make decisions without data. And if we're concerned about health equity, it helps to have data on health equity. So I was really intrigued to hear about the work you're doing to try to come up with a consistent and broadly based survey of health equity. And I think it'll be interesting to see how that work develops. Let me take those 2 points and then pose a question to Martin. One of the things that's often observed is that decision makers are often forced to make decisions under conditions of uncertainty. They can't wait to make a decision about allocation of more money to health or education or transportation until all the data are in. But they often just go ahead and make those decisions without necessarily having the right kind of perspective. So the question for you, Martin, and you've been, you're such a veteran of health decision-making at every level in Europe, both from your work at the London School and the European Observatory. What steps can we take to ensure that evidence-informed decision-making to promote health equity and healthy societies goes beyond healthcare and incorporates data on the social determinants of health?
Well, that's basically a political question. Bismarck is alleged to have said, although it's difficult to know where the original source was, that 2 things should never be made in public: laws and sausages. And that's because the legislative process is often rather more messy than we would like. I think what we should be asking, if I may broaden it, Jeff, is how do we make it so that legislatures actually enact laws and policies that are based on evidence, full stop? Because if we could do that, then we would be in a much better position to get the social determinants of health in place. Now, a famous quotation from a former law lord in the United Kingdom talked about the practice of binge lawmaking. Now, we in the United Kingdom have a particular problem because we don't have a written constitution. At the minute, we have a government that has a massive majority in the main chamber, and we have a second chamber that is unelected, which has therefore very limited say. And it does mean that all sorts of things can get through without any adequate scrutiny. A famous example was an education bill that was laid on the floor of the House and had to be withdrawn because as an education bill, it was found to be full of spelling mistakes. So, you know, it goes on and on and on. And there is a famous book called The Blunders of Our Government. Now, the United Kingdom is not uniquely bad in making incompetent and ludicrous laws that are unworkable. But, you know, we do particularly well. We're well up the league table there, and we don't have the checks and balances. So that's the first thing. But in terms of the social determinants, actually, to my mind, one of the biggest arguments here is that if you don't address the social determinants of health, then they're going to come back and bite you anyway. And I think many senior clinicians actually recognize this. You're picking up the pieces of a failing social system if you're working on the front line of medicine. I mean, that was why I moved into public health as a junior doctor many years ago when I was seeing cases of beriberi and scurvy in Northern Ireland. And it was clear, even though I didn't know the language, that I was actually working with the social determinants of health. So I think there are a lot of people who get that. But of course, then you've got to translate that into action. And there, I think there is a challenge. And here, maybe we have a transatlantic divide here to some extent, because a lot of this depends on whether you've got a health system that you visualize as being there to promote health and to prevent impoverishment, or whether you look on the health system as basically a financial instrument for making profits. And clearly, depending on what your view is, then your approach to the social determinants of health will be different. After all, if you're making more money from treating people, you have, even though it might be rather cynical to say this, an incentive to get as many people sick as possible. Whereas if you actually are trying to improve the health of a defined population, then your incentives are rather different. Now, the challenge, of course, is, as I say, people in health systems, I think, get this. However, I'm not sure everybody else does. And I'd like to quote from a leading world politician at the minute, our Prime Minister in the United Kingdom, who only the other day who said, and I quote directly, and in fact, my wife suggested that had we been able to, I would show you a video clip, because his words are so incredible that you really need to see it to realize that he did actually say it. It's not like under the previous administration in the United States where the expectations were rather different. So Boris Johnson said, I've given you the most important metric. Never mind life expectancy, never mind cancer outcomes. Look at wage growth. That's what I mean by leveling up. So that's the challenge that we're up against. And so therefore we need to overcome this. I would just maybe digress a little bit and I say that when we do look at the determinants of health, of course, there are people who really do want to focus on the individual. And much of the literature on commercial determinants of health, the tobacco industry, the gambling industry, the alcohol industry, the junk food industry, is very much about individual choice and a very libertarian approach. And it tries to drive public health downstream into educational schemes and individual interventions rather than addressing the social determinants properly. So we need to recognize that, and we need to be able to decode the language, because these people who are often well-resourced are often very willing to offer their help to us in public health, saying we are here as part of the solution when they clearly aren't. Now, clearly, we're coming out of a pandemic. At least we would like to think we're coming out of a pandemic. We have no idea what variants will come about. And this really should be our opportunity, because although we can say in the same way that in the past people have looked at the social determinants of infectious diseases, this is a virus that has hit different people in different ways. And the burden of the pandemic and of the pandemic-related responses has been very unequal in our societies. And the societies that have done best have not been those that have been best prepared using things like the Global Health Security Index or something like that. They have been the ones that have had the strongest health systems and the strongest political leadership. So I think that as we go forward, we need to say that one of the main reasons why some countries were hit much worse than others in terms of health and in terms of the economy was that some of them had failed to put in place the social and health protections. They had created a population that was living precarious lives, precarious in terms of their income, their employment, even their food supply and their housing. And that was what created the conditions for the virus to spread rapidly. And because we had failed to create the trust and the social capital and the cohesion and the digital inclusion and access to justice and all of the other things. Now, we've been writing about this in the Pan-European Commission on Health and Sustainable Development, which I was a commissioner on, led by Mario Monti, former Italian Prime Minister and European Commissioner. And we have set out a scheme which I think overlaps a lot with what your report is saying. We're saying very much the same things. We definitely need data, but we need to use it in a productive way. So I'm not sure if that answers your question, Jeff, but I hope it helps a little.
Well, Martin, that you've broadened our discussion out to actually, you started by saying that I had asked you a political question. And you came back in the end to political questions, because the way in which social protection, public trust, allocation of resources to a strong social safety net, those are all ultimately political questions. And the question I'd like to pose to all of the panel now is, again, one of the perspectives in the 3D Commission was that unless the communities who are directly affected by health conditions and the social determinants of health have a say in what policies are put in place to help address those conditions and to help improve health for everyone, we're going to always have the kind of tensions and fault lines that Martin was just talking about. So maybe each of you could talk in a way about what can be done to ensure that decision-making that affects the health of populations incorporates the perspectives and the needs of different stakeholders who have a stake in the decision-making process. I mean, Martin, do you want to, would you like to start,
Yeah, sure.
Since you raised this question?
Well, my hero is Rudolf Virchow, and he said that the answer to the typhus epidemic in Silesia in the 19th century was democracy. And I think that, how do we get people's voices to be heard? Well, we have a system by which people's voices should be heard, and that is through the ballot box. I mean, we can look at other ways too, but fundamentally, people need to be able to be heard through the ballot box. And I think at this point, both in your country, Jeff, and in my country, we need to look at the policies that are being pursued by your previous administration, but also the administration, particularly at state level in states like Texas and others, and the policies that are being pursued by the current British government, which are blatant voter suppression, making it more difficult to vote. Now, if people cannot be heard there, if they're marginalized, if they're put into some sort of out of sight, that's a fundamental problem in allowing people's voices to be heard. So we cannot get away from the politics. There are lots of other ways that we can do this too, but if we don't have a functioning representative democracy, which is not just the tyranny of the majority, which allows for the diversity of voices to be heard and make sure that everybody has a voice, because you can easily have what appears to be a democracy and where it looks like the majority is there. Let's take a country like Australia, where the Aboriginal population are a tiny proportion, but with a 20-year gap in life expectancy, their voices need to be heard too. So it's not just about a majoritarian approach. So we need to have mechanisms that allow people's voices to be heard that way. And that means that then they choose whether they will be heard or not. And the danger is that people like us choose whose voices we listen to. So we need to be very careful with that.
I think those are both critical and important points. Sival or Terje, how do these issues look from your point of view?
Actually, Professor Mckee already covered all the points that I would like to emphasize. I mean, democracy, a pure democracy, a real democracy is really very important in order to get all the voices of the stakeholders involved in the decision-making process. So I think this is the most important thing, not a certain group of people should decide, or a certain level of people involved in decision making, but all the stakeholders needs to involve the decision making process and should be aware about the importance of the data, first of all. If they don't know the real situation, what's going on in terms of social determinants of health, for instance, so they cannot involve the decision-making process. In addition, the policymakers who are taking decision also should be aware, as I mentioned at the beginning of my talk, should be aware about the importance of all this data, the accuracy of data, and there should be political willingness for data-driven approaches. So I think Professor Mckee already covered. The main issue is democracy in here. If there's no democracy, we cannot get the voice of all the stakeholders in the field. So not only, not only the government should be accountable, but also the civil societies, different groups, vulnerable groups. Versus nowadays, actually, I would like to talk, if you give me a chance, I would like to talk about the refugees versus in Turkey. I mean, Turkey is also part of Europe, and Europe also is a main problem. We have a lot of refugees nowadays. So refugees should be also part of this decision making. I mean, we are talking about a huge amount of numbers, 5 million, 10 million people who are suffering, because those are the most unguarded groups in terms of social determinants of health, because of difficult living conditions, sheltering and nutrition problems, difficulties at getting health care and social services, and violence. Just at the end of 2020, there were 82.5 million forcibly displaced people in the world, and according to UN High Commissioner for Refugees report, which more than 26 million are refugees. And this number has doubled since 2010, and higher now it has never been. And more displaced people have fled Syria than any other country. And for instance, Turkey now tops the list of countries taking in refugees. So there are many challenges, and there are many different groups, different stakeholders should be in this cycle. Thank you. If you have time, I would like to talk more about the refugees, how it happens, how as a Turkey, because I work as an advisor to Minister of Health, as well as I'm a member of EU COS group. We are a group of academicians working on to improve health of migrants and health of refugees. So I would like to talk how we use this data on social determinants of health to improve health of at least Syrian refugees. Do we have time?
Well, let's stay with that for another minute, Saval. Refugees and migrants are it's a difficult case when we're looking at social determinants, because to go back to what Martin was talking about, if we argue that policy is the outcome of the interaction of interests, refugees are a difficult case because they have no political standing. And therefore, they have no interest in that contest for influence. So, how do you think that the use of data can help improve the policy decisions that are made with respect to refugees and migrants?
I mean, if they know the real status of the health status, at least of refugees, so they can take action accordingly. Versus in our case, what we did actually we are not so used to, because in Turkey we did not have too many refugees or too many migrants before. Only 1.8% of our population before migrants or refugees. But with the influx from Syria, now the number of refugees around 6 million. I mean, the registered one is around 4 million, but it is more than that. We all know that. What we did, we tried to provide a holistic approach to them. First of all, we established a good data collection system in order to understand who they are. I mean, can you hear me?
Yes, yes.
In order to understand who they are, not only their health status, but also their educational level, their background, so on. So we established a good data collection system, first of all, to understand the current situation. And then accordingly, we try to decide some strategies to improve their health. And we also use some different survey. For instance, this is European with Institute of Migrant MyPEC study. So with MyPEC study, we also try to understand the equity issues, you know, among the refugees and all the European countries. And based on all data, for instance, we open some. First of all, we involve them also to the decision-making processes in the region. We give opportunity to them and to cover all their health expenditure free, like the nationals. So they have the entitlements and accessibility of health really high in Turkey. They are same as like nationals, because we saw that, you know, it was a main problem. So the second one is what we did, there was a language barrier. So we opened some migrant health centers, provided all the healthcare and all the other educational, health education or all kind of educational activities in their language, so on. So, you know, of course, with the help of EU, I mean, we work together to improve their health status in terms of social determinants of health, indeed, and also try to involve them into the decision-making with some representative from their groups. I mean, they have some small civil societies, so the representative from their civil societies, try to understand the real problem and accordingly take action. Also, influence the politician. I mean, we work together with Minister of Health, Minister of Education, Minister of Family and Social Welfare, so on. So I cannot tell you that you know, they accepted all our requests or all our activities, but they try to you know, follow our advisors in this process.
Well, thanks. So it's a highly complicated problem, and it sounds like you took a fairly comprehensive approach.
Yes.
Terry, would you like to come in on these issues?
Definitely, certainly. So I'll try to integrate the perspectives that have been raised so far a little bit. So starting with the last, the refugee situation, I think it's relevant to bring up because this is a European launch, and the refugee situation has been a key issue in the European policy and also health debates during the last few years. And this leads us to the focus on vulnerable groups. So as a commission, I think the 3D Commission should and is also focusing on vulnerable groups as one of the key perspectives. But there are many of them. Refugees are one example, and we should also think in terms of combinations of vulnerable groups. So being a person with lower education, you know, being a refugee, being a woman, being born in it, you know, looking at the combinations of this disadvantage. But at the same time, we also need to look at where what governments can do something about in the daily activities, including refugees that includes the total population. So we need to focus on vulnerable groups, but we also need to focus on the whole population, on the social gradient that goes from the poorest to the richest, and that's where our people are. So and that's how we can influence the health of populations by voting on the parties and politicians that are aiming at doing something about the social gradient in our societies. And that's how I was trying to go from the refugees and back again to the governmental level. So we need to inform governments about and show them the data, show them that that health is something that goes from the poorest, those with less education, those with the most harmful working conditions, and so forth, to those who have the most power and prestige and are living the wealthiest lives. And if we are going to improve the health of our populations, we need to think actually about everyone, also those in between. And this is about government. And so I agree with the starting statement by Martin, that politics basically is a larger scale of social medicine. I think Rachel was the one who said that as well, wasn't it? But we cannot force people to vote on the parties that would be most of benefit for them. In the end, it's about how politicians present their messages, and that can fool us. That can fool us, each and one of us. The way that sometimes more populist governments and politicians are presenting their messages and leading us perhaps in the wrong direction. In Norway, where I'm currently based, we have recently had a change of government from a more conservative government to now it's going to be a social democratic government. And we were, as a group, focusing on inequalities, invited to a meeting just right now, and that did not happen the last 8 years. So I definitely think that the type of government we have, that will affect who they're listening to and which advices they choose to take. But I think as well that we as researchers, we should also focus on what we can do something about. We cannot force people to vote on certain parties. We shouldn't do that. We should make sure that people can make their own choices. But there are some things we can do. We can assure that that our evidence, what we show them, is correct and of high quality, that it's that we make sure that data is actually available, used in a best way. But we can also make sure that we have continuous interactions and with policymakers to the extent basically that they will allow us to. And I have higher hopes now in Norway that this will improve over the next years. So governance matters.
Yeah, no, I think that we would all agree with that, particularly your last point. Martin, before you have to leave us, would you like to make a final comment on this, the nexus of data and decision-making that Terje and Saval were just talking about?
Yeah, I mean, there is an old saying that data makes decision-making very difficult. It is, as you alluded to at the beginning, much easier to make decisions when you don't have to worry about the facts. And particularly as we're living in a post-truth era, which we certainly are in the UK at the minute. And so therefore, I think data are quite important. One of the things maybe we haven't said enough about is accountability, because data are important for holding our elected leaders and our unelected leaders to account. And of course, that's why some of them don't particularly like it. And if we have strong, we've got the lessons of history here, like when the Soviet Union stopped publishing its mortality data in the 1980s. But we also need to be very careful, because even if governments are not going to stop, are just going to not going to go that far, what they may do is they may erode the investment in the data collection. Now, as you alluded to in your report, there are many other sources of data. In fact, many sources of data that we often are unaware of. And I mean, we've just had a Facebook outage, of course, that reminds us of the vast amount of data collected by the social media companies. And of course, we've had the very important whistleblowing accounts, which have let us into that world a little bit. So there is a wealth of data there, some of which we know about, some of which we don't. That raises issues of power, but that's another issue. But I think the use of data for accountability, particularly as we're saying that we actually do elect governments to protect us as citizens, not just to protect us from foreign invasion, but to protect us from all threats. And that includes threats to our health from wherever they come. And this is one of the ways in which we can begin to hold them to account. So I'll say thank you very much and drop off.
Okay, well, thanks for that comment and your others as well, Martin. It was really a pleasure to have you with us, and we'll carry on, but we know you have other commitments today, so thanks so much. Sandra, let me, excuse me, let me pose a question to you based on the conversation we've had so far, particularly based on this last comment that that Martin made, that we elect governments to protect us from threats, including health threats, and that the kinds of data that we collect and deploy can really help to make better decisions and to hold governments accountable for those decisions. Maybe you just reflect on that that set of issues in the context of what Terry and Sival and Martin have had to offer.
Yeah, thank you, Jeff. I actually thought that Martin had one other clause, which I really liked in that statement, where he said, having data makes decision-making harder. And I actually thought there was a provocative thing to say, of course, having just had the privilege of leading a commission for the past 2.5 years, which has really surfaced the importance of data to decision-making. And Martin saying, well, in some respects, it actually makes it harder. And of course, what he meant, I think, is that data introduces it makes the invisible visible and introduces an expectation of accountability that often decision-making gets away without having to take responsibility for. And I thought that was a really important comment, which says we often avoid using data, not because it's just not there, but also because it's inconvenient. In my own scholarship, I'm a population health scientist by profession. And in our research team, I often tell our trainees that, as far as I'm concerned, a lot of what research is about bearing witness. It's about using data to illuminate what is happening in the world so that then we may act on it. And this conversation reminds me a lot of that. And so I think it actually adds these layers of complexity, that it's not simply a technical question of having the right data available. It is also a conceptual question of making sure that we want data. We actually want to know what the question is, and we want to act on those data. And that requires a culture change. In pulling together a report like this, which is a tremendous amount of effort, the question often asked is, why does one do a report? And I think there is appropriately enough substantial cynicism about the utility of reports, and I am well aware of that. But the reason I think these efforts are important is because they contribute to shaping how we think about things. So it's my hope that in insisting that data are important to decision making and data that capture social determinants are important, that it slowly shifts the tide. And we see that in many ways. I mean, many examples where we see tides shifting, culture shifting, manners of thought shifting, and this can be one of them. So that was a long answer, but it was a really interesting question.
Yeah. Well, I think, and I like where you came out, Sandra, because yes, the 3D report will contribute to shifting how we think about these issues. I certainly hope so as well. But also, I think what we've heard in the last hour from Terry and Sival and Martin is that the themes of the 3D report resonate with the work that they've already been doing. Your comment about researchers bearing witness in a way is really important. We heard Sival talk about the work she's done on refugees in Turkey, and that was a way of bearing witness to the situation they're in, and using data and an awareness of social determinants to help shape policy around how to help them, both with health conditions and other issues. And Terje was talking about inequalities in Norway. I mean, those of us who live elsewhere tend to look at Norway as kind of a Nordic paradise where there is no inequality. But that obviously isn't the case. And now with the change in government, there's an opportunity to bear witness to the challenges that are still there, and to use data and a knowledge of determinants to really help improve social policy. And I think that's, it's just really encouraging to hear how the work that we've been working on resonates with what others like Saval and Terje and Martin have been doing. You know, we have just a few minutes left. I'd like to just turn to Terje and Saval and give you each a minute to just make any final comment you'd like to make about the themes of today's workshop.
Certainly, if I may start. So basically, there's no country in the world where we have found no inequalities. So social inequalities in health have been observed in all countries with available data, and even in a country like Norway, and the inequalities are also increasing. So this is a global problem with relevance everywhere. And I also want to stress that it is now perhaps more important than ever to monitor the changes in health according to our social standing after the pandemic, because we have to admit that there are really no good evidence on what really helps to reduce inequalities. I mean, there are some, but at the national, local, and European level, we see that interventions aimed to decrease inequalities are very, very often increasing them, although population health, that's important to mention, is improving. But we now have a historic opportunity to measure the true value of welfare systems in insulating their populations from rising social inequalities in health in the face of widespread social disruption. So health inequalities, they are increasing all over the world. And now we have a chance, a really rare chance, to measure how much these increases are affected by the degree of social protections in each country of Europe. Because we know that the pandemic is really hitting societies unequally. So we now have a chance to see, as a natural experiment, if solid and comprehensive welfare state is part of the answer on what are protecting not only populations, as full, from the richest to the poorest, but also vulnerable groups, in light, of course, of what Cyril brought up earlier. So we shouldn't stop now with the evidence presented in the report. We need to go on with the work and monitor and collect data that are sensitive to socioeconomics. So we also need to improve our research infrastructure with a comparative scope. We need to make sure that the data becomes available for researchers, for policymakers, practitioners, and we need to bring research organizations, policy institutions together in dialogues like this one. So thank you for inviting me.
Thank you for that, those fascinating insights. And Saval, you have the last word.
Yes. Thank you very much. Yes, of course, the data, the collection of data, analysis of data, interpretation, all these are very important, as my colleague already mentioned, and we already experienced during COVID-19 period. But I think the most important thing that I would like to emphasize, training. I mean, yes, a group of people, public health people, we are very much aware about the importance of data and data-driven decision-making. But I think we need to involve, we need to influence more groups, as you mentioned, as you asked to us at the beginning of the webinar, the stakeholder. We need to influence more stakeholders. And I think in this sense, training, especially training of physicians, nurses, and other healthcare professionals to address social determinants of health and should make them aware that this is one of the key principles for promoting more equitable health outcomes for patient families and communities. Yes, nowadays, most of the schools, they are already integrate the social determinants of health into their curriculum. But I think we need to work more on this issue, and we need to start at least this public health training and the training on social determinants of health since the beginning of medical school or medical colleges or nursing school. As your first webinar, one of our colleagues mentioned that this training should be integrated to the primary school. I totally agree with you on that. Even to integrate this, the importance of data on social determinants of health, the curriculum of allied healthcare professionals, medical school or nursing school, not enough. We need to integrate the curriculum of secondary school or college level or something like that. So I would like to emphasize this. And I would like to emphasize also the interpretation of data. There are a lot of maybe data. Of course, the accuracy, the timeliness, and reliability is very important. We need to check, as Professor Mckee already mentioned, I mean, before to decide what's going on, we need to be sure that this data, really the data we need to take decision, we need to use for decision making. So we need to know how to interpret data. I mean, more sophisticated techniques that the scientists using sometimes not working at policy level. As mentioned, for some time I'm working with the ministries and with different political groups. So we need to know to speak the same language with them. So we need to interpret, yes, for instance, global burden of disease study. I'm also one who carried burden of disease study for Turkey. Wonderful. But when it comes to the terminology, the technical part is really very hard. And it's very difficult to convince the policymaker by using terminology. So as a conclusion, I think interpretation of data, to speak the same language of the policymaker, to use the data appropriately is very important. And for this, training is very much important, and to create awareness among all the clinicians, all the other healthcare professional group, as well as other sectors, because this is multi-sectoral. The social determinants of health is a multi-sectoral issue. I think we need to do that. So training. Thank you very much.
Okay, thank you, Seval. And also, Terry, I wanted to thank you and Martin Mckee as well for a very lively panel discussion. We've covered a lot of ground with some really important insights from each of you. With that, I'm afraid we're out of time, and I'll just hand back to Sandro to close us out.
Well, thank you. The only challenge with those concluding remarks is that actually there's another hour of conversation I want to have to build on those concluding remarks now. So I will not, but I will then take the occasion simply to say thank you to Jeff, Terry, and Seval, and also to Martin, and thank you to the audience for joining us, and thank you to everybody who thinks about these issues and is slowly moving towards creating a world where we actually do have better approach to understanding social determinants through accountable, transparently collected data with accountability to make better decisions to improve health for all. Everybody, thank you. Have a good rest of the day, afternoon.